Welcome back to Prescribing Hope, Azithromycin Unmasked. I'm Rittika, your host with a master's in neuroscience, driven to uncover the science behind azithromycin's multifaceted role in medicine. In today's episode, we are going to talk about azithromycin and chronic respiratory diseases and take a very close look at it. We are exploring how antibiotic transform the management of chronic lung conditions and what that reveals about immune modulating powers. Today, Saakshi is back to walk us through different stage chronic respiratory illness where azithromycin plays less of a sword wielding hero and more of a steady gardener, trimming inflammation with care.
Thanks, Ritika. I am excited to dive into azithromycin's role in chronic lung diseases. It's like shining a light on a quiet hero in the respiratory world.
Let's eliminate that hero's work, shall we? Azithromycin is a mainstay in managing chronic respiratory diseases like cystic fibrosis and COPD. Can you detail how it mitigates these conditions, focusing on its antibacterial and immunomodulatory mechanisms, and cite specific clinical evidences supporting its efficacy?
Absolutely, Ritika. In chronic respiratory diseases such as cystic fibrosis or CF and chronic obstructive pulmonary disease or COPD, persistent airway inflammation and recurrent infections drive exacerbations, worsening lung function and even quality of life. Azithromycin's dual action, antibacterial and immunomodulatory, makes it a cornerstone therapy. Its antibacterial effect, targeting the 50S ribosomal unit to halt protein synthesis, clears or controls pathogens like Pseudomonas aeruginosa in CF or cystic fibrosis, or Streptococcus pneumonia in COPD, reducing bacterial load in sputum by nearly 1 to 2 log units as shown in CF trials. However, its immunomodulatory role is equally critical. Azithromycin suppresses pro-inflammatory cytokines, IL-6, IL-8, and TNF-alpha by inhibiting NF-kappa B and AP pathways, reducing neutrophil infiltration and airway damage. In cystic fibrosis, low-dose azithromycin, nearly 250 to 500 mg thrice weekly, decreased exacerbations by 35 to 50% and improved forced expiratory volume, FEV1, by 5 to 10% per a 2003 New England Journal of Medicine trial with 185 patients. In COPD, the Columbus trial, 2011, The Lancet, showed 250 mg daily azithromycin reduce exacerbation frequently by 27% in 1,142 patients, alongside lower IL-8 levels in sputum. These benefits often persist even without active infection. Highlighting azithromycin's ability to calm chronic inflammation. Its high lung tissue penetration, which is 1 to 8 microgram, ensures that these effects are localized, minimizing systemic side effects. This dual mechanism stabilizes airways, reduces symptoms like wheezing, and enhances patient outcomes in these lifelong conditions.
You have portrayed azithromycin as a dual guardian, wielding a bacterial slaying sword and a soothing balm to tame the inflammatory tempest. It impacts in CF and COPD is like a lighthouse guiding through patients through chronic respiratory storms, anchored by robust evidences. You emphasized that its immunomodulatory role in chronic inflammation. How does this compare to its effect in acute respiratory infection? And why does azithromycin seem more effective in chronic versus acute settings?
Great question, Rittika. In chronic respiratory diseases like CF or COPD, inflammation is a slow burning, persistent fire driven by constant immune activation and microbial triggers. Azithromycin's immunomodulatory effects, reducing IL-6, IL-8, and neutrophil elastase, work best in this setting because low dose, long-term regimens, example 250 milligram thrice weekly, allows sustained suppression of NF-kappa B and macrophage polarization to anti-inflammatory M2 phenotypes. This gradual modulation, seen in CF trials where IL-8 dropped 50% over 6 months, aligns with the chronic, smoldering nature of these diseases, improving lung function and reducing exacerbations over months to years. In acute respiratory infections like community-acquired pneumonia or CAP, azithromycin's role is more about rapid bacterial clearance, with its anti-inflammatory effects playing a secondary role. In CAP, high-dose azithromycin, which is 500 mg daily for 3 to 5 days, quickly eradicates pathogens like Mycoplasma pneumonia, reducing symptoms in 48 to 72 hours per 2015 test studies. Its cytokine suppression is less impactful here because acute inflammation is transient and often resolves with bacterial control. The short treatment duration limits immunomodulatory benefits, which require prolonged exposure. Additionally, acute infections often involve diverse immune dynamics, viral co-infections, where azithromycin's effects are less predictable. Chronic diseases with their consistent inflammatory profile are a better canvas for azithromycin's immune modulating brush, making its impact more pronounced and measurable than in the fleeting chaos of acute infection.
Sakshi, you have framed azithromycin as a patient gardener, pruning the chronic inflammation of cystic fibrosis and COPD with steady care. While its quick strikes in acute infections like a sprinter's dash, less suited for deep immune artistry. Its chronic efficacy shines like a slow burning flame. This chronic disease success inspired its COVID-19 use for inflammation control. Can you please explain how azithromycin and its anti-inflammatory effects were hypothesized to benefit COVID-19 patients and why they fell short of this viral acute context?
In COVID-19, severe cases were marked by a cytokine storm, an acute hyperinflammatory surge of IL-6, IL-1 beta, and TNF-alpha, driving ARDS and mortality rates of 20 to 30% in ICU patients per 2020, the Lancet data. Azithromycin's chronic disease success, like reducing IL-8 in cystic fibrosis, led to hypothesis that it could dampen the storm. Its ability to inhibit NF-kappa B, reduce neutrophil influx, and lower IL-6 by 50% in vitro per Journal of Immunology 2004 suggested that it could stabilize lung tissue in early COVID-19, prevent progression to ARDS. Its lung-centric pharmacokinetics, 80 microgram per ml in alveolar macrophages, made it ideal for targeting pulmonary inflammation. Early 2020 studies like the Gottritz in International Journal of Antimicrobial Agents reported reduced hospital stays with azithromycin hydroxychloroquine combos, fueling hopes of immune modulation plus bacterial prophylaxis. However, these hopes crumbled in large trials. Recovery 2021, The Lancet, tested azithromycin in 2,582 hospitalized patients, finding no reduction in mortality, 22% versus 21% or ventilation. Principle 2021 showed no recovery benefit in outpatient settings, 7 versus 8 days. The issue here was timing. Trials often enroll patients 7 to 14 days post-symptoms when lung damage was already advanced. Unlike cystic fibrosis chronic setting, where azithromycin works preventatively. COVID-19's acute viral-driven inflammation, with cytokine levels 10 to 100 times higher than in cystic fibrosis, overwhelmed azithromycin's modest effects, unlike corticosteroids, which slashed mortality by 30% in recovery. Resistance risk 20 to 40% in S. pneumonia, and cardiac concerns, 0.1 to 1% QT prolongation, further limited its use, showing its chronic disease, showing its chronic disease finacy, sorry, showing its chronic disease finesse did not translate to COVID-19's acute cures.
Sakshi, you have depicted azithromycin as a seasoned healer of chronic ailments, thrust into COVID-19's raging inferno with tools too gentle for the blaze. Its inflammatory touch, its anti-inflammatory touch, like a soft rain, couldn't quell the viral deluge. Revealing context is king. This contrast raises questions about azithromycin's broader application. How does its efficacy in chronic respiratory disease versus its COVID-19 shortcomings inform our understanding of its immunomodulatory limits? And what does this mean for the future in acute viral infections?
Azithromycin's tale in chronic respiratory diseases versus COVID-19 is a lesson in immunomodulatory precision. In CF and COPD, its efficacy stems from sustained, low-dose modulation of predictable inflammatory pathways, IL-6, IL-8, NF-kappa B over months, reducing exacerbations by 27 to 50%. Example, Columbus and recovery trials. Chronic inflammation is a steady drumbeat, and azithromycin's subtle, targeted effects, like reducing neutrophil elastase by 50% in cystic fibrosis, aligns perfectly, offering long-term stability without broad immunosuppression. COVID-19, however, presented an acute chaotic symphony, a cytokine storm with IL-6 levels 10 to 100 times higher than in cystic fibrosis, per 2020 Nature study. Azithromycin's modest cytokine suppression, 50 to 70% in vitro, was insufficient against this surge, and its short, high-dose regimen, 500 mg daily, lacked the duration needed for meaningful modulation, unlike CF's chronic approach. Trials like Recovery showed its effects were drowned out by viral-driven pathology, unlike corticosteroids' broader immune suppression. This highlights azithromycin limits. It excels in chronic bacterial-influenced inflammation, but falters in acute viral-driven hyperinflammation. For future acute viral infections, azithromycin's role should be narrow, perhaps as an adjunct in mild cases with bacterial co-infection risk, 10 to 20% pandemics, or in patients with chronic lung comorbidities where its cystic fibrosis-like benefits might apply. Resistance, 20 to 40% globally, and cardiac risk, 0.1 to 1%, demand caution, and future use requires biomarker-driven trials, example IL-6 levels, to identify responsive subgroups, ensuring
We couldn't hear you.
ensuring we wield its immunomodulatory scalpel with precision, not as a blunt tool in viral crisis.
Sakshi, you framed azithromycin as the master sculptor for chronic inflammation, carving stability in CF and COPD, yet a mere bystander in COVID-19's volcanic eruptions. Its limits, like a candle in a gale, guide us to wield its power wisely in future battles. Thank you, Sakshi, for this deep dive into azithromycin's respiratory legacy. I'm Rittika, and this is Prescribing Hope, Azithromycin Unmasked. Stay curious.